For my talk this afternoon, I want to talk about pharmacogenomic test ordering and clinical implementation. This is kind of the nuts and bolts of how we're setting up our programs both at IU Health and Eskenazi. So again, I'm going to talk about this. The programs between the two hospitals are very similar. Now, there's some peculiarities, idiosyncrasies with both hospitals that we are effectively working around, but the programs at the 30,000 feet level are very, very similar. Talk about the overall plan, the timeline, when all this is planned to begin, and then I want to walk through an example patient case. So again, to kind of give you a little clinical orientation for this. All right, so clinical pharmacogenomics at IU Health and Eskenazi Hospital, and the philosophical question, excuse me, are we there yet? No, but we're fully engaged and certainly getting closer every day. And we all think that clinical pharmacogenomics is the journey to enlightenment. That's for sure. Division of Clinical Pharmacology has programs in development to implement clinical pharmacogenomics at IU Health and Eskenazi Hospital. And as part of this program, we have a very broad-based approach to this. We've identified 24 pharmacogenetically significant and clinically actionable medications that are going to be part of this system. This was a long process for us. It was based on a careful and as well as an ongoing review of the clinical evidence. The big thing about this list of 24 that is certainly not set in stone. This is a dynamic list. Believe it or not, we didn't start out with 24. I think at one time we were flirting with 50 or 60 at some point. So again, and this list of 24 will not be maintained. There'll be, if you want to put it this way, winners and losers on this list, medications that will certainly add to this, and some will take off as more clinical research comes to the fore. As you know from earlier, there's about 14 to 16 CPIC medications have been reviewed. Obviously 24 is greater than that, so we think that there are a number of medications that have not quite yet been CPIC reviewed that are important. So we have included this on our list. And you'll see this list in a second here. So, and this is going to be a computer alert driven system, excuse me. This computer alert will inform the clinician of the availability of a pharmacogenetic test when one of those 24 medications is prescribed for the first time. And after the pharmacogenotyping is done, the patient consents. A report will appear in the EMR for the clinician to review. And I have an example report for this. And also, it's not just standalone. If there's still some questions or concerns, depending on the medication and the gene, they can, the clinician can also request a pharmacogenetic consult for further advice. And I've got a clinical workflow schematic here to give you a better idea of how it's all going to work together. So, excuse me, patients will be identified when prescribed one of the 24 target drugs for the first time. The computer pop-up will tell the clinician, hey, one of these drugs is important from a pharmacogenetic standpoint. So the clinician will consider that. He'll ask the patient. Hopefully the patient will consent. And then the pharmacogenotyping test will be done. And this will appear in the EMR, the report from this. And if the clinician still has some issues or some confusion or just wants to ask some questions and wants to get a formal pharmacogenomic consult, that will also eventually make its way to the medical record. Now, the IU Health program and the Eskenazi program, these are very large clinical studies. So as such, we're going to be collecting a lot of data on this. And some of the endpoints we've identified already, and there will be more to follow, are things such as patient morbidity, mortality, adverse drug events, quality, and cost. So we'll be collecting data on this as patients make their way through. All right, here is the list of 24. The ones in red with the asterisks are the CPIC reviewed, and the rest are ones, again, that we think are important enough to warrant inclusion on this list. So I won't, again, this is nothing you have to commit to memory, but these are the ones that we will be looking for. All right. So the big $64,000 question, and it may actually be more than that, is who is going to pay for the testing? All right. Well, right now, the IU Health, we have a portion of the Strategic Research Initiative grant that is going to be paying for this study. It is limited to the number of subjects or patients. It being a clinical study, anywhere from 2,000, maybe a little bit more than that. It's going to be centered here in Indianapolis on the IU Health campus at this point. And we've also applied, just submitted this last month, I believe, for an NIH U01 research grant that, if awarded, and we'll find out soon, this year, that will take care of the Eskenazi Hospital. So again, these are large research grants, and it'll be a fairly similar program at Eskenazi, as I mentioned before, as it is at IU Health. But I do want to make this statement that private insurance, though we complain a lot about them, there's some indication that they are paying for this. Dr. Flockhart may be able to answer with a little more authority than me, but it is variable and somewhat unpredictable. There's been some success with 2D6 and 2C19, but again, there's always this opportunity. So if you have a patient, it's always worth asking that question. But here on campus at IU Health and Eskenazi, the subjects will be screened and paid for with these two grants, and hopefully the U01 as well. So timeline. Okay. We're hoping for the fall of 2013 for the IU Health. We'll see. That may be pushed a little further now, maybe, right, Vicki? Maybe, yeah, thereabouts. It's going to start narrowly, initially with clopidogrel, but we're also going to be engaging some of the other MDC clinics at IU Health, again, to capture some more of those list of 24 medications. And then we anticipate rollout to Eskenazi in early 2014. All right. So let's try an example patient, and this will give you an idea of how we want our program to work and how a patient will kind of wind their way through this with the clinical pharmacogenomics. Got LJ this time, 56-year-old gentleman with hypertension, type 2 diabetes, comes in with hypercholesterolemia, and you like to start him on simvastatin. So you should all know about simvastatin by now, I hope. Current medications, glipizide, lisinopril, some aspirin, an MVI. LG is placed on simvastatin, as we know, and as if you remember from the list, simvastatin is certainly one of our 24 targeted medications. So again, clinician orders simvastatin on the computer, which activates a pop-up window, all right? And this is what we think the window is going to look like, all right? Maybe not exactly, maybe little tweaks here and there. But the first window, again, since this is a research study, it's going to ask if you want the patient included in this clinical study. And if so, you check that. This will activate our research coordinator to contact the patient to obtain consent. Also on this little pop-up here is a little bit about the study, what's going to happen with the patient. Blood will be drawn, as you can imagine. Pharmacogenomic panel will be performed. Results will be reported in the EMR for relevant new start medications prescribed. And then, based on the targeted medication, results of the pharmacogenomic testing will be provided. And then again, can't stress this enough, a consult will be available if needed, okay? Based possible on CPIC guidelines. Again, not all the 24 have CPIC guidelines, but the ones that do will certainly be relying on that. So this patient agrees to screening and for potential variants that could affect his statin therapy, simvastatin therapy, and we get a genotyping is performed, and the clinician is then later informed that the pharmacogenotype report is available, again, all via computer. And this is an example report here. Again, this is our patient, LJ. A little bit about his past medical history, some medications, that kind of demographic information. And these are our results. And if we look, and what this table shows is the genes we screen for and the cytochromes, as well as some of the other enzymes, the result here, and then the phenotype that's expected here. So again, he's Silco 1B1 star 5, which, as you recall, is a poor metabolizer phenotype. But I also want to draw you down here to CYP2D6. Now, for this particular question, we're worried about the statin. But because this is a broad-based approach, and because our genetic lab platform is going to look at all of these, you're always going to get potentially some additional information that could be clinically relevant for your patient. So again, we're all concerned about the Silcos here, but we also can't ignore this CYP2D6 poor metabolizer status as well. In addition to that report of the data, you also get a clinical interpretation, a couple paragraphs here, which summarizes the important findings of the test. And again, it'll just kind of reiterate what's going on with this patient. He's on simvastatin, was prescribed. He has this genotype. It's a poor metabolizer. It will also have a link when it exists for the clinician to click on for the CPIC guideline for simvastatin or whatever drug it is. But also, again, it's not going to ignore that CYP2D6*4*4 or any other possible genotype that pops up. And it makes this recommendation here. Please review the patient's medication list for medications metabolized by CYP2D6, because again, this would not be something that you'd want to overlook. And again, here is the boilerplate statement here. If you have any questions regarding drug selection or any questions about the lab results, give us a page and you can request a formal pharmacogenetic consult. All right, so here's the CPIC guideline. I know you've seen this quite a bit now, but again, this is what will pop up when the clinician, or something similar to this, will pop up when the clinician clicks on that in the EMR report. And again, we know all about this now and know about the alternatives. So the clinician will be able to work through this themselves if they feel comfortable. And if they still have some questions, they can still order a consult from us. Right? So to show you that I think the power of our broad-based approach is that we are screening for many variants. And so it's important for that one drug, simvastatin at the time, but it's also the power of our program is that it's also good for future drugs. And again, patients only need to be screened once now for this. So again, and this here is the future here. And it's our patient LJ again. He's been cleaning his garage, hurt his back, strained his back, ordered some, tried a little over-the-counter ibuprofen, not enough, and he's requesting something stronger. Okay, so he gives your clinic a call and says, you know, I really screwed up my back. I'd really like something better than ibuprofen. So again, a physician gets on the computer, says, okay, great, we can take care of that. We'll order some codeine. Okay, can you see a problem happening, perhaps, with a poor metabolizer and codeine, hopefully? Okay, all right. And here is the pharmacogenomic alert that'll pop up. Okay, again, this is a future medication. And what it does is it gives you a little rundown of what the pharmacogenomic issue is. We know the patient was the 2D6*4*4. He's a poor metabolizer, so he's not going to be able to make that morphine metabolite very well. So you're going to have a therapeutic failure. So again, this would not be a good drug for this patient. And it shows that under the implications section, and you already know this already, and then also gives some management recommendations. Now, these are CPIC guided recommendations, okay? And also be able to click on this as a clinician and get directly to that guideline if you need some more information. And again, the same options are available. If you're still trying to figure out how to proceed from there, you can certainly request a pharmacogenetic consult. All right. So our pharmacogenomic plan at IU Health and hopefully Eskenazi as well, we think it's broad. Again, we're looking at 24 different medications, and that list of 24 can get pushed up higher or less. It's a dynamic list. We can change it as more clinical data emerges or as some medications become less important. It's scalable. We think that our approach to this can be used at other centers, and we think it can be larger than even what we have proposed here at IU Health and Eskenazi. It's clinically robust and responsive. Again, I get back to this broad list approach that we've come up with, and responsive. Not just, it doesn't cover medications that patients on right now. It covers the future ones. Again, we've got the pharmacogenotype. It's going to be the EMR. It's going to any new medications. It's going to be able to circle back to that EMR and let us know of any future issues. And we also think that data generated from our research will provide insight and direction for implementation of clinical pharmacogenomics at other centers. We feel very strongly about that. All right, questions? Yes, ma'am. Yeah, you got to. I guess you got to press and hold. I think.
Oh, is there any kind of collaboration with the biobank initiative for IU Health with the work that you guys are doing? Because that's already a repository that exists currently.
Yeah. Do you want to comment on that, Dave? Yeah. Press the button up there. Yeah. The one below. Yeah. There you go.
From a population perspective, not necessarily an individual perspective.
In the 2 research studies that we have described, every sample that is collected will have an aliquot go to the Indiana Biobank. And the Biobank, just so everybody knows, is a universal consent across all our campuses that allows the collection of a DNA sample, actually any kind of sample you want, but DNA sample and access to that medical record. So the patient's providing access to their medical record for researchers. So this will quite significantly increase actually the number of samples in the biobank, this initiative.
Yep. Short answer is yes. Yeah. Yes, yeah.
Do you want outcomes?
Outcomes.
Yeah, of this plan.
Yeah. Of the research, or yeah. I mean, yeah. That's ongoing work right now. Certainly, trying to come up with the right approach to that. But the outcomes that we'd like to that we've centered a lot on is the economic outcomes. That's one that's tricky but can be measured, and we're working with the cost of taking care of patients that don't have pharmacogenetic genotyping done versus the ones that do. And also we're going to be looking at morbidity, mortality, those kind of typical ones. And it gets, as you drill down and get more granular, it becomes much more and more complex for given based on sample sizes and the drug gene pairs we've mixed as part of our 24. But we're also looking at adverse drug events and those kind of issues. But where all these funnel to is in cost of care.
Just a follow-up to the question that was just posed, is what's exciting to me about this is outcome measurement, because that's where healthcare is going, is outcome measurement. Not only are we providing a phenomenal service, but it's outcome measurement. And there's more outcomes than just cost. Certainly that's something that we have to look at. But we have some set groups that we can compare ourselves to. There are other groups like Vanderbilt and others that are doing these too. And so there's some measurements that we can compare that. And we can also then compare against general population data as well.
Oh, certainly. Yep. Yeah. Definitely. Yes.
Brian, I understand this is for research, but what is the current policy for, whether the insurance company is going to cover whenever, the physician make an order?
Yeah. Well, it's the reimbursement's always been an issue. We talk about the standard of care, but sometimes I wonder if the standard of care is if the insurance company pays for it or not. But it's very variable. Again, the testing that'll be done as part of these research studies will, of course, be paid by the grant. But and Dave, you can interject any further details as you see. But it is a variable process, and not every insurance company will reimburse for these kind of tests, and that's just part of the challenge.
I think that the point here is, what we're really saying is that this testing is going to be available. We put a lot of time and energy and money into setting it up. So Vicky, a CLIA-approved lab that can do this stuff, and the stuff that we do as part of the research will go into the medical evaluation system. But we're also I'm able now to order in my clinic stuff that I have to send out to be done at other labs. What the presence of the lab here allows is I'll be able to order the 24 drug thing here for my clinical practice as well, and everybody else will.
Yes.
What is your turnaround time with lab?
That's a great question. And actually, we've got that. You're in luck because we have the two lab people here sitting in this room.
Because I see you're starting with the clinics.
Yeah.
Instead of maybe starting in the cath lab, particularly with.
Well, actually, that's great. I'll let Rolf talk a little bit later, but that's where the clopidogrel will begin. Is in the cath lab. So that and yeah, and the turnaround time for clopidogrel, Vicki.
Well, right now, we don't have that established yet, but in general, it's going to be about 1 week.
Okay. For the panel.
For the panel.
Okay. Yeah. But for the one drug, obviously a much faster time frame for that.
We would anticipate that would be the same for warfarin, basically. Someone ordered it for about 1 week.
Right. Yeah, we're in the process of, when we're getting set up, we'll be assessing that and seeing how quickly we can get it out.
There's another question?
Yeah, first of all, the combination of the research and the application to clinical practice is really exciting, and I like the overview. Is this going to apply to inpatient as well? I found myself trying to walk through your process and thinking that every time I order anything, pravastatin's the only thing on formulary, so I couldn't go through the simvastatin example because I was wondering if any of your meds on your list are going to get kind of hamstrung by formulary.
Yeah, it's certainly it's gonna cross over in both inpatient and outpatient is the plan.
Ryan, that like codeine, I can verify with you after the meeting, I think has been removed in the IUH system completely. Yeah. Simvastatin's not in the system either, so there might be some more.
Yeah. Thank you.
I think with time we'll find that the inpatient question is an important one because in general, pharmacogenetic labs and genetic labs in general don't have the kind of turnaround that you need for a patient who's going to be in the hospital for 3 days. I'm holding the microphone. The inpatient question is important because very few people stay in the hospital more than a few days. So, actually doing the test and getting the result while they're in the hospital is very unlikely, but increasingly there'll be a larger and larger number of patients who either will have been tested here or elsewhere, and we'll have an interpretation of that test, even though it wasn't done as part of this admission. So it's a slow, gradual process. On the reimbursement thing, the early stuff that we have had with it, I think, has been that while it's unpredictable, reimbursement absolutely is not zero. So the way I tell patients is, you have a chance at getting it reimbursed, and a lot of them want it done.
Yep. Very good. Any other questions? Yes, Ken.
I think the other thing is that the fact that it's going to be done in two quite different institutions at Eskenazi and IUH will allow a really good analysis from not just from a clinical utility, but from a health economics perspective, looking at private payers versus CMS, Medicare, Medicaid. And I think that will help too, because I think we'll be able to look at payers of all types and be able to provide some very good input about that health economic benefits in all type of payer systems.
Most definitely, and obviously an IU Health patient can be very, very, very different than an Eskenazi patient, both in comorbid disease as well as payer sources, et cetera. So I think that just makes, again, this two-pronged approach and going towards these two different health systems, and we think of them, they're all on Indianapolis campuses, but they're very, very different, as most of you are aware. So I think it definitely makes our approach and much more powerful. And I agree completely with Ken. It's going to provide some useful information, again, hitting both of those different patient populations. Any other questions or concerns or anything? Okay, very good. Thank you very much.